everybody these days thinks that they need to do PGT. And we're going to chat about it and talk about whether or not it's useful in cases where there is severe male factor. So welcome back. It's been a very, very busy week for us. Lots of IVF going on, lots of IUI, and some business stuff that we've been attending to as well. I've been back and forth to Toronto. My great new friends at Create have been amazing. I love all the ladies there. So if you're watching, hi girls. Thank you so much for your incredible, incredible efforts on our behalf. We love you. And to all the patients that have been there so far, we've had very good experiences, great success rates. So lots of good things happening from there. So we'll let you all get settled in. Welcome back for all those that are watching. And hopefully you'll take interest in this topic. I managed to get it up a couple days early, so hopefully more people will be interested in listening in. And we'll see what you all think. So we'll give you guys a few seconds to get on. I will say that I did have an amazing opportunity through some local assistants, who shall remain nameless, but highly appreciated, to approach certain elements in our government to try and get funding for our IVF program. So we don't know anything about it yet, but we'll see how that all pans out. And with some luck, we'll make it work for everyone so that our program has funding as well. But who knows? We'll have to see what the future holds and do our best to try and move forward as we can. So hopefully all of you guys have been safe and well. I had the opportunity to talk to one of our frontline COVID workers as well today. She is a family physician in town that's doing a lot of the COVID work. Still says the numbers are very much there. We had more just in the first few weeks of August than we had in all of July. So there is that concern about the second wave. So please be very careful. Continue being vigilant, washing your hands, sanitizing constantly, and making sure that you are wearing a mask and protection wherever necessary. That is really, really important to making sure that we are doing the best job we can to make sure that we're accommodating everybody and taking good care of everyone out there. So be really, really cautious about that. Okay, so we are going to get started. I don't see too many people on our Facebook version of this, but maybe they're signing on. Usually it sort of pops up, doesn't it? Yeah. I don't see anything there. In any event, so we're going to talk today about pre-implantation genetic testing for aneuploidy in severe male factor infertility. So we've reviewed PGT-A before. As many of you know, I don't believe in PGT-A for younger patients. The STAR trial, S-T-A-R trial, that we reviewed here on Fertility Fact or Fiction and is available on our YouTube channel from several months ago, showed that there was no benefit to doing PGT-A in younger women. What is PGT-A? That's when you make your embryos, you grow them out to the blastocyst stage, so they're now mature enough to use for doing a biopsy to determine if the embryo is normal or not. You do the biopsy, which involves lasering the embryo, allowing a little hole right next to where the placenta is forming. The placenta then extrudes through the embryo, or through the shell of the embryo, I should say. And then you're able to use a laser to kind of trim off a piece of that placental tissue and send it without any damage to the actual portion of the embryo that's going to turn into the baby, which obviously would be detrimental. We then analyze those cells. They use special techniques to amplify the amount of DNA, and then they analyze it and say, is this chromosomally normal or is this not chromosomally normal? And they can figure all of that out with the special testing that they have. Bottom line is that that whole process, when you're looking just at chromosomes, is called PGT-A, and that stands for pre-implantation genetic testing for aneuploidy. So it's a very useful test if you do need, for any particular reason, to rule out that the embryos are normal or abnormal. The problem is, initially, everybody thought this was, again, one of these holy grail situations in IVF and started doing it for everybody. Adds expense, adds complications, adds complexity and time. Plus, you have to freeze, which is a good thing, but nevertheless, you have to freeze the embryos to do it. And when that happened, everybody said, oh, this is great. We're finding out which embryos are normal or not. We're tossing out all the bad ones. Problem is, it actually doesn't improve your success rates. So these guys decided to kind of hone it down and have a very sort of specific look at a different question. And that question was, What if the problem is that the male has obviously very poor sperm? Well, ostensibly you would think if the sperm is very compromised, that may represent a problem where you're not getting the same results. You're not having the same outcome. And maybe guys with very weak sperm, they have more problems. They may not be as good as the guys with normal sperm, so maybe they have a higher rate of aneuploidy or genetically abnormal embryos. So aneuploid just means not euploid, and euploid means genetically normal. So, maybe these guys with severe male factor have higher rates. So the study is quite interesting, and I wanted to review the data with you guys because it's always good to kind of, recheck everything that we're doing, have a look, make sure that it's absolutely perfect, and that the research that we are presenting you with is correct for everybody. So maybe other people sat there and thought, well, my partner has really severe male factor. Maybe this doesn't apply to him. Maybe we should look at a different study. Okay, so this study did receive ethics approval from their ethics review board. It's a single center study, actually done in Turkey. So not that Turkey's like the mecca of IVF, but it actually is a very well-developed country. It has the world's 9th largest economy. They have lots of IVF centers, and there actually are a lot of good studies that come out of Turkey. So essentially what they did was they chose men with very severe male factor, less than 1 million sperm per milliliter, but they were genetically normal, their partner was normal, and the age groups were actually quite reasonable. So the ages were between 25 to 39 years for the women. 25 to 39 years is relatively young in the IVF world. We certainly have women that are much older doing IVF. And so this was a very reasonable thing to take a look at. They dealt only with single embryo transfers, which makes it easy. And they looked at the groups in terms of, was there a euploid embryo or an aneuploid embryo, to make sure that they knew what was going on. So with all of that in mind, they analyzed initially 795 couples between January of 2016 and March of 2019. And from those 795 couples, they eliminated all the women above 39 and less than 25, people that did fresh cycles because they were only comparing frozen to frozen, which makes sense. They got rid of the double embryo transfers, early transfers, day 2, 3, or 4, men who just had absolutely no sperm, women with uterine anomalies, acquired uterine pathologies, chromosomal abnormalities, poor endometrial lining. So they're really narrowing down this field to exactly the people you want. Medical conditions, which they left kind of blank, and then those who had missing data. So after they excluded everybody they needed to exclude, they ended up with 266 couples out of the 795. So a huge shrinkage and compaction of that data, okay, important. From that 266, you had 90 people that did do pre-implantation genetic analysis, and you had 176 people that did not. Okay, so between the two groups, there were differences, and this is really important. So I'm going to pull up the study for those of you on Facebook and YouTube and so on. Just give me 1 second here. For the rest of you, I will show it to you in a second. Okay, let's put that in the middle. Okay, so if you go down to this portion here, and I'll try and blow that up for you so you guys can all see it. So you can see anywhere where the p-value is less than 0.01, you're actually dealing, or sorry, less than 0.05, you're actually dealing with something that is statistically significant. So looking at that data, and again, I apologize to the Instagram folks. Sorry, guys, there's no way to show you this at the same time as we're showing on the other platforms. But essentially, the female ages were different between the two groups. So PGT-A average age was 34, non-PGT was age 30. So obviously the women in the PGT-A group were a little bit older. Male age, same thing, 36 versus 34. Advanced female age, which they considered greater than 35, greater than or equal to 35. I am not trying to disparage any women that are over 35. This is just their definition. It was 42.2% versus just 14.2% in the non-PGT-A group. So there were some significant differences between these two groups. Why is that important? Because if you are comparing apples to apples, you're comparing apples to apples. But if you're comparing apples to something completely different, like a watermelon, you can't compare them. So you have to make sure that the groups are comparable, or do the statistical analysis to control for those findings. And they did do that later on. There were a lot of smokers again. So this is a sort of pseudo-European population in Turkey. 13.3% in the PGT-A group were smokers, 12.5% in the non-PGT-A group. Interestingly, a fair number of patients had previously tried infertility treatment in the PGT-A group, and a very high percentage had had multiple previous failures. So 77.8% of the patients that did PGT had actually failed before, versus only 14.8% in the group that did not do PGT. So all of these are really, really critical. Also a higher difference in the number that had had recurrent pregnancy loss, which they defined as more than 2 losses. Okay, so where does all of this take us? Well, if you look at the data again, the next table really was not very valuable, but this table is quite interesting. So this is comparison of ovarian stimulation and vitrified warmed blastocyst transfer characteristics and the luteal support regime. So essentially, there were no differences in any of the groups except the blastocyst, the number of vitrified top quality blastocysts was statistically different, but was numerically the same. So this is like fractions of a point, but they both had 1 for top quality blasts in both groups. The blastocyst rate was a little bit higher in the group that did not do PGT-A. So maybe that's a suggestion that you're damaging the embryos, who knows? And the top quality blastocyst rate was definitely higher in the group that did not do the testing on the embryos. Everything else was essentially the same. So maybe there's an impact on the embryos. It's a little bit hard to tell. Nobody knows for sure. Indications for the PGT-A. So actually their number 1 indication was repeated previous failures. Advanced maternal age was the number 2, plus repeated failures. And then advanced maternal age alone, much lower. Recurrent pregnancy loss, much lower. Patient request was significant, about 12 patients, which was 13.3%. So those were the reasons why they did it. Okay, so here's the most important part. What actually happens when you go through this? Well, you can look at every single outcome, and none of them made a difference. Biochemical pregnancy, odds ratio was 1.15 in favor of doing the PGT-A, but not significant. Implantation was 1.06, not significant. Clinical pregnancy, 1.19, not significant. Miscarriage was less in the PGT-A group. Again, not significant. Live birth, not significant, and multiple pregnancies were low because they were only doing single embryo transfers, and again, not significant. So even in these men who have very severe male factor, and their wives are actually pretty healthy, youngish women with no significant problems, there is no benefit to doing the PGT-A. Now, everybody should be saying, well, wait a minute, didn't you tell us a moment ago that there are problems with the data because the 2 groups were not equal? That is correct. The 2 groups were not equal. So what they did was they piled all of these numbers into an equation called an ANOVA, or a multivariate logistic regression analysis. And they then sat down and said, okay, if we control for all of these factors, is the result the same? And the answer is, yeah, none of those confounding variables, advanced female age, male age, repeated previous failures, recurrent pregnancy loss, duration of infertility, or even the PGT-A testing, had any impact on the outcome. So they actually did screen for that. They did calculate for that. So bottom line is, PGT-A still is not useful, even if it's severe male factor. Now, granted, this is a relatively small study, only 90 patients with PGT-A, but no one's done it this way before, looking exclusively at severe male factor. So does it help to do PGT-A in cases with severe male factor? No, it is a fiction that severe male factor will be benefited by doing PGT-A. It is still unnecessary, especially in a young population of women less than 39 in this study, older than 25. And so it is not necessary in that group. Save your money. It's not going to help you guys. So do not do the PGT-A. The study that came out with the STAR trial had lots of commentaries around it. And Richard Paulson, and I've talked about this before, who's a very well-known fertility specialist, said, listen, when he did the calculations, he said, you're going to lose up to 50%, 50% of your genetically normal embryos when doing PGT-A because you discard them thinking they're abnormal or not use them, when in reality they're perfectly fine to use and can yield a healthy, happy baby. So don't do PGT-A unless you're older. Once you're over 38, 39, there is some value to doing it just because the statistics start to demonstrate that there's a very high rate of abnormal embryos, and you don't financially want us putting in embryo after embryo that's abnormal until we get to a good one. But below those ages, don't bother. It's not going to help you guys. So save your money. Do not fall into that trap. Even if the fertility center is telling you to do it, don't. One fertility center in Toronto in particular really forces people to do this. And they're telling even young women to go through this for no good reason whatsoever. The science isn't there. It's a money grab. So don't do that, okay? Make sure you save yourselves the hassle and, go ahead without it. It'll probably save you money, and it'll probably end up with the same or maybe even better success rates. So avoid it. It's not necessary. So thank you again for watching that segment of the show. That was Fertility Fact or Fiction, where we always cover a hot topic. This is a study that's just about to be published, not published yet. It will be in Reproductive Biomedicine online if you want to find it. The lead author was Mehmet Resit Osoglu, A-S-O-G-L-U. That individual is the main author on this study. And like I said, it's in Reproductive Biomedicine online, so you can find it. Again, the title is Pre-Implantation Genetic Testing for Aneuploidy in Severe Male Factor Infertility. So we're going to take your questions like we always do. Make sure you like, subscribe, and comment on our YouTube channel. That's www.youtube.com/Dr. Victory, D-R-V-I-C-T-O-R-Y. We love the input. We need the feedback. We've got loads of videos there, and we hope you get a chance to watch some of those. All of our fertility factor fictions are put there for you, usually within a few days of the time that we do the show. Okay, questions. You have questions for me? No, you don't have questions from there. I got to see how I'm going to pull them up from here. For sure. I don't know if I have the new one. I'm not sure if I can see the ones that people posted.
Okay, I'll pull it up for you.
Okay. So Tara's going to try pulling up some questions for us. If you have questions, definitely drop them. We've got some friends on Facebook, so I'll go through those ones. I had a question, not related to genetic testing. I had my egg retrieval today and misunderstood and accidentally took a dose of PIO this evening. I was scheduled to start tomorrow for my fresh transfer on Saturday. How does this affect my chances of successful implantation? It could, although it's unlikely. So if you're going for a day 5 embryo transfer, the likelihood is high that you're actually going to get the same result if you do a day 5 or day 6 progesterone and then transfer in a day 5 embryo. So unless you've massively overblown your progesterone, 12 hours should not make a huge difference. Having said that, it can accelerate your endometrium. And in theory, if there is enough asynchrony between your embryo and your lining, it can result in the embryo not wanting to implant. So I would talk to your doctor about that. They may want to freeze, and that might be important. If not, I think you'll be fine, because like I said, the likelihood is very high that day 5 embryos can be implanted after 5 or 6 days of progesterone with the same outcome. And we actually just reviewed that on another episode a few weeks back, so that should be fine. Apparently people couldn't see the data, so I apologize, but I'm not sure why that happened. It was being shared, so I'm not sure why that happened. in any event, I did call out all the data. Any more dates for surgery yet? Surgery's a nightmare, guys. I spoke to our chief, and there is virtually no chance of getting anyone in for surgery anytime soon. It is super difficult. We're getting one day every several weeks. Right now, I think it's every 8. I used to have one day a week, sometimes extra when I needed it. So it's going to be forever. Surgery is not going to happen quickly, and unfortunately, it's going to take a long time no matter what we do. And there's nothing we can do about it. So for some people, I'm able to take them to Create to do minor procedures because they have an OR there. We're actually thinking of setting one up here in Windsor as well. But it's a lot of effort and a lot of cost, so I'll have to figure that out. I have asked if the hospital will at least lend us one of the towers to use for that to see if we can do it here, but we'll have to find out.
I have all of them.
You got all of them? Sure. Yeah. Let me go through a couple here. Does doing here's good. Does doing PGT-A help if you're 38 years old and you have diminished ovarian reserve? So that's a great question. The problem is we actually don't know. So nobody knows if doing that is helpful or not. It may be, and it's entirely possible that it is, but we actually don't know that. Now, 38 is the cutoff where we actually do recommend you do PGT-A, but it's not because of studies that demonstrate it's beneficial. It's actually because it looks like the responsiveness of the embryos, or the normalcy of the embryos after the age of 38, is definitely compromised. At least a minimum of 2/3 up to 75% of your embryos are going to be abnormal starting at 38, and it just keeps getting higher with each successive year. So when you're dealing with that significant high level of abnormal embryos, maybe it's worth checking, not so much because it's going to improve your success, but because it's going to decrease the number of embryo transfers it gets. If I have to do 3 or 4 embryo transfers on you to find the normal one, number one, you're going to be super frustrated, which isn't going to help. And number two, you're talking about a problem financially too, because now we've spent thousands of dollars putting in embryos that never should have gone in you. So that's a very different number and mode than when you're younger and many of your embryos are normal. Okay, so great question, and thank you for asking. Okay, let's go here. Is PGT-A also PGS? Yes. So PGS stood for pre-implantation genetic screening, and PGT-A is the term they implemented to replace that. So they are interchangeable, and PGT-A is now used instead of PGS. What are your thoughts on the Ramsey theory? Do you think the location of the placenta has any indication on gender? Placenta on the left side for girls. Never heard of that before. Virtually every single theory on placenta location has been tried, tested, and all shown to be totally bogus. If you want to know the gender of your child, pay the extra money. You get the NIPT test. It's a simple blood test. They'll tell you with 0.0001% accuracy if it's a male or a female. So it's simple. Just pay for the test and you'll know what you're having. Don't bother wasting time with which side the placenta's on. Oh, here's a good one. Can I explain duostim and how it would be beneficial to a patient with diminished ovarian reserve? Okay, so this is actually one of our fertility factor fictions from 2.5 months ago or so, 3? Maybe 2? Okay. So from a while ago. And duostim is a really interesting idea, and there is actually a lot of evidence, multiple studies that support the use of this, and we've started doing it ourselves. So duostim is when you go and you have a patient who doesn't necessarily have the strongest ovaries, and you take that patient, you put them through an IVF cycle, you capture all the eggs that you can, you wait 5 days after the egg retrieval, and you immediately start your next retrieval, your next stimulation, and do a back-to-back retrieval. So the idea behind this is that follicles and ovaries come in waves. So there's a first wave, and then there's a second wave. And that by doing a back-to-back cycle, you can actually capture both waves. So that's really important because by capturing both waves, you manage to get all of the things you want out of it by getting more eggs, more embryos, and actually some of the studies are suggesting you're getting better quality eggs and even better quality embryos. So this is a useful sort of setup. Now, what we did to try and make it helpful for patients is we dropped the cost of the second cycle by about a third. So you're actually paying 1 2/3 instead of paying double. I don't know that everybody's doing that, but we tried to package it to make it, sort of appealing to patients and obviously helpful because these are patients that are struggling to begin with. So the cost of the meds is a lot higher because you're doing 2 stims, but the cost of the IVF is a lot lower, so you're saving that element of it. And we are starting to see some successful outcomes with this. So hopefully we'll let you know more on our own personal experience as we use it more and more. But we are using it to help our patients, especially the ones where they don't do great in that first round and they were expecting to. And then we just tell them, look, for a little bit more, you can do another cycle and you don't have to worry about it as much. So it's helping patients in that regard. So that's what DuoStim is and how it helps. You want to fire off?
Yeah.
Yeah, go for it.
Does a low AMH cycle indicate infertility?
Does a low AMH indicate infertility? It doesn't indicate infertility. It indicates compromised fertility. So if your AMH is low, it means that your ovaries are slowing down. And if your ovaries are slowing down, it will be harder to get pregnant. The egg quality can be compromised. The egg number will be compromised. And so the risks of miscarriage, of abnormal embryos, and so on all increase significantly. So that is an important factor, but it is really important because if you're getting low, you may not have very much time to actually pursue your fertility goals. So make sure if your AMH is low, you're seeing a fertility specialist. That's very, very critical.
Do you recommend taking a muscle relaxant for transfer over-the-counter options?
I definitely don't recommend a muscle relaxant. We do use Valium in patients that are anxious. Don't use a muscle relaxant because almost all of them come with a non-steroidal anti-inflammatory. You're not supposed to use those during implantation. So no muscle relaxant, but you can use a Valium or an Ativan or something like that.
What can be done for a contracting uterus the day of transfer and following days?
So if your uterus is contracting on the day of transfer, you probably should not be transferred. So that's important because if your uterus is contracting and you put the embryo here and your uterus is doing this, the embryo is going in a direction and it's actually going to just wave itself out of the uterus. So that is definitely not ideal. And they've actually got really cool studies with, I think it was electron micrographs or X-ray, where they put a radio active little dot in the uterus and watched it while it was contracting. And you can see the thing waving its way out of the uterus. So that's not a good outcome. So my embryologist says, wait an extra day, increase the progesterone and wait another day and the uterus will calm down. But you do need really close monitoring. If it's persistently contracting, you got to rule out infection. So that's where doing that fertility testing for infection from inside the uterus can be really useful, or doing an endometrial biopsy, although that's not that helpful often. And if it's still persistently contracting, you either got to bite the bullet and try, or you need to look at not using that uterus. There are no medications that have proven useful for this, including atosaban, which is an oxytocin receptor antagonist, which blocks the ability of the uterus to contract. Even that was not shown to be beneficial. So there's nothing you can take right now that actually helps in that regard. Let me take one or two from here. Is there a minimum number of blastocysts to make PGT-A testing worth it in older women? That's a great question. So from a financial standpoint, if you're being charged per embryo transfer, basically the number of embryos is going to make a difference that you have to transfer. So if you're doing 2 single embryo transfers and you're doing them all frozen at let's say what we charge, which is roughly $2,000 per transfer, you're looking at $4,000. So yes, then doing PGT-A with 2 embryos would make sense because of the fact that it's going to cost you roughly it's going to cost you roughly, sorry guys, $4,000 for the PGT-A, and it's going to cost you roughly $4,000 to do the embryo transfers. So in that specific case, it totally makes sense to go ahead and do the PGT-A because your dollar value is the same, and so you'd rather know than be going through medical treatment, shots, all that progesterone in your bottom, which has its own side effects and impact. But if you're only doing one embryo, unless you're going to do multiple cycles in a row of natural cycle IVF, where you're only yielding one embryo, I don't think one embryo needs it. I mean, it doesn't make sense to go through all the extra expense because if you put in a genetically abnormal embryo, it's got an over 98% chance of not taking. So why would we bother torturing you with all of the expense, $3,000-$4,000 of doing a single embryo when we could do it for virtually, nothing, or do it for nothing, and just take that embryo, put it in you, and if you're pregnant, you're pregnant. The chances are high it's normal, and if you're not pregnant, you can virtually guarantee it was because of the genetics. So my number is really kind of one. I think that's an important distinction. You want to do another one from there? Yeah, sure.
What can be done? Oh, no. What's your biggest piece of advice to someone just beginning their fertility journey?
Oh, great question. No one's asked us that before. What's my biggest piece of advice to someone starting the fertility journey? Probably three things. So number one, find a really good center that's knowledgeable, that is experienced, and that is not after you as a dollar sign, but are actually there to try and help you conceive. So that's number one. Number two, I would definitely recommend that you find someone that you are comfortable with. You want someone that you feel has your back and is trying for you and wants what's best for you and is going to help you through this journey. And then number three, make sure that you are, under all circumstances, remaining calm and trying to navigate through this as a journey. A lot of people show up and kind of have these expectations that we can kind of snap our fingers, give you something, and it happens overnight. The reality is this is often a very bumpy road, and it can take quite a bit of distance to get to the destination. So hang in there. Make sure you have comfortable, co-passengers or co-pilots with you to navigate that road, and make sure that, they're taking you on the journey, holding your hand the entire way. But you got to be patient during that journey. If you are constantly looking all over the place, forwards, backwards, second guessing where you're going, always feeling disheartened or, like you're not going to get there, it will impact the journey for you, and it can make it so that you eventually run out of gas. So stay hopeful, stay positive, and make sure you find the right team to help you out. I'm 30. Here's a good one. I'm 32 with a unicornuate uterus. What are my chances of conceiving through IVF and carrying to a viable stage? So that's a great question, but it's kind of impossible to answer without knowing all the details. So I can't answer based on that sort of limited information. Reality is that you need to do, all the tests, go through all of that, and then look at it. Your uterus, even with a unicornuate, can actually carry right through to term. Most women with a unicornuate uterus don't find out until they deliver, find out the baby is breech. They need a C-section. They go for the section. Doctor sticks their hand in there and goes, wait a minute, this is a unicornuate uterus. So it's very frequently undiagnosed until way, way later. So I'm not too concerned about you being unicornuate, and IVF is a great way to go. We have one patient who's been with us for a number of years with a unicornuate uterus, and she's done great. I did keep her upside down for part of one pregnancy, but she's subsequently done really well and had good outcomes and everything. So, there's lots of hope there. I wouldn't worry about that at all. We are male factor infertility and have had 2 FETs of untested embryos each. Both transfers failed. Blood tests all normal. I am 35, no issues, and embryos have been frozen since I was 32. Any other suggestions, tests for next transfer? Lots. So make sure your vitamin levels are high. Make sure your stress levels are low. Make sure no one is smoking, drinking, or using any kind of drugs, especially marijuana. Make sure your weight is appropriate. Make sure your stress levels are low. Make sure that they are monitoring your progesterone levels, the compaction of your lining, and whether or not your uterus is contracting. All of those are important. Make sure you're getting a good embryo transfer at the right time with the right amount of progesterone, estrogen, and so on. And before you do anything, I'd actually advise thorough investigation of the female. So make sure that you are being checked for the possibility of endometriosis if you have access to that. Maybe check the lining of your uterus for infection through Fertilysys. That's fertilysys.com. They're a company in Greece that tests your uterine lining to see if there's hidden infections there, and that can be very, very important for treatment. So all of these things are really critical. You need to address all of those, make sure that everything is perfect. So make sure you are checking all of those, and then if everything is crystal clear, go ahead again and try again. If you still fail or you don't want to go ahead again, the other person to talk to is a reproductive immunologist. I've talked about my colleagues, Fred Zineku and Chloe Remain in Toronto. I'm more than happy to refer you to them. Just give me a shout out and I can put you in touch with them. They were amazing people. I like to think we're very like-minded. And we work very well together. So same kind of personalities. They're very patient focused. It's not about the money. They really want to help people. So good people, good program, and they actually have very, very high success rates. So that's a reasonable option. I can take questions from you because I think we are done on FB.
Okay. What do you tell your patients about TWW?
What do I tell my patients about the 2-week wait? Don't test because it'll drive you mental. Try and stay calm. Follow all the steps that you need to follow. So try and be as normal as possible. Stay on all your meds and your vitamins. No extremes of anything. Hot, cold, spicy, sweet, cholesterol, not cholesterol. Exercise, wrong time to try running a marathon, wrong time to start watching and practicing 50 Shades of Grey. So, you want it all to be pretty sort of average. That probably makes the most sense. What's most likely the most important element is do whatever relaxes you the most. The less stressed you are, the better off you're going to do. So that's really my advice during the 2-week wait. Pray if you're, into prayer. I have a question in Spanish, I think. Mulher na menopausa pode fazer tratamento para engravidar.
What are they saying that to you?
I think that means if I'm near menopause, is there any treatment to get pregnant? I vaguely understand Spanish.
Okay.
So the answer is it's very difficult to get pregnant when you are near menopause. So if you are near menopause and you are trying to get pregnant, it is very, very difficult. It's possible, but it's difficult. The chances are low. Chances of miscarriage are high. So if it's covered and you don't have to pay for it, then great, go for it. That's a great idea. It's a great choice. And I would strongly encourage you to do it. If you have to pay for the treatment, I would be very reluctant to let you pay for treatments when you are near menopause to try and help you get pregnant. I actually saw a post from a different company not too long ago, just a couple of days ago, on Instagram saying that there was great news that injecting PRP into a woman's ovary had made women start to ovulate again and they were getting their period back, and this might be the breakthrough. It's total nonsense. Nothing proved that they're making genetically normal embryos, and they're not making genetically normal embryos. And there is no study that has demonstrated improved success rates for PRP injections into the ovary. So menopausal women or near menopausal women really need to be cautious because unfortunately you can be victimized very easily trying to get pregnant. When would you do a natural versus medicated FET cycle? Is one more successful than another? I wish I knew the answer to that. I do. The answer is nobody knows. So every week someone publishes a study that says the stimulated one or medicated FET is better, and then next week someone publishes one that says the natural is better. 2 weeks ago, we literally had that. So one study said that the medicated was better, or at least the same, And then a week later, they had another study that said that if you are doing a natural cycle, your miscarriage rates are lower. So no one knows the answer. We tend to do it stimulated because there's more control, or medicated because there's more control. And we've had very good success rates with that, so I don't hesitate to do it. But there are some people that fail with the medicated, and those are good candidates to try natural, or vice versa. So that's not, unreasonable. Here's a good question from Facebook. Is it possible to switch our initial consult with you to a Zoom meeting? We are scheduled for next week. We've done several IUIs and 2 cycles of IVF. Wow, it's been a long journey. Okay, so first of all, I'm very sorry for what you're going through, and absolutely, I'd be more than happy to Zoom you. So just let the office know, 519-944-6400, or you can email Mara at drvictory.com, and she will arrange for that. So absolutely, you can take care of that very easily, and we will happily convert to a Zoom. And again, I'm sorry for what you're going through. We will definitely try and find a way forward for you. My retrieval was Saturday, 20 eggs collected, 16 mature, 12 fertilized. I'm 36, husband is 42. Questioning PGS testing. No PGS testing. You're too young, it's unnecessary, don't waste your money. The STAR trial clearly demonstrated that it is of no benefit to you. And the follow-up analysis showed that it was actually even more significantly not helpful than the original trial said. So do not do PGS testing or PGT-A testing if you are 36 years old. It's not necessary. And you got loads of eggs and good embryos coming, so don't worry about it. It's a waste of money. Save your money. It's not necessary. You got one over there?
Oh, yeah.
Fire.
Having my progesterone levels checked 2 days before transfer, what level should it be at?
So we use nanomoles per liter. So we like it kind of between 50 and 100, 40 to 80, 50 to 100 in that range. So that's the target you're looking for. Minimum sort of 40, 50 is best. Lower than that, we start getting worried.
Well, that was the last one from the early questions.
I think we may have our first ever early show. Oh, here's another one.
There you go.
You guys, if you have questions, fire away now, because otherwise we're going to shut down the show soon. It seems like we don't have as many questions. Also, is there any benefits to waiting for frozen transfer to get more normal cycle? Okay, so there are loads of benefits to doing frozen versus fresh embryo transfers. First of all, if you had 20 eggs collected, you're going to hyperstim if you get a fresh transfer, so don't do that. Secondly, your lining is overblown with estrogen, and that has impacts on the pregnancy. So multiple studies have now shown that there is an increased risk of preeclampsia, small for gestational age babies, intrauterine growth restriction, preterm labor, all sorts of complications when you are going into a fresh IVF cycle, especially with high levels of estrogen, compared to a frozen embryo transfer cycle where the babies are normal in size, there's no growth restriction components, and the preeclampsia rates are lower. So there are many benefits to doing frozen embryo transfers. Most people should go for a frozen embryo transfer. There are some exceptions, but the majority should go through frozen embryo transfers. So yeah, I would not go fresh. You're definitely going to hyperstim if you had 20 eggs collected and 16 were mature. Total no-brainer. You will hyperstim. Then you'll be in hospital with a belly full of fluid, and that would be a problem. How long should you wait? I love this on-the-fly question and response. Yeah, so wait for your next period, which should happen roughly 2 weeks from your retrieval. And then you want to go on to whatever meds they're going to put you on, or a natural cycle in the next cycle, at the most the next one. But you basically just need to wait a month and a half, and you're ready to go. So you don't need to wait too long. It should be fairly easy to try quickly, and then jump back on board and get what you want done. Someone wanted to just pop on to say hi. Hi, hope you're doing well. What about eras for a 39-year-old woman who has unexplained no health issues, infertility, and have had 2 failed genetically normal embryo transfers? Wow. Oh, okay. So we just reviewed ERA last week. ERA's own study demonstrates no benefit. For every 7.2 women that do an ERA, one extra patient will get pregnant. It is not financially beneficial, even from their own data, and most of their own data shows no benefit in general. Certainly when you use the intention to treat analysis from their data, there is no benefit. It was only when they looked at it per protocol where patients actually stuck to what they were supposed to do that they saw a small benefit, and that was only cumulatively, which means multiple tries. So should you do an ERA? Probably not. I do get the frustration after trying twice, but it does not look like it's helpful. What should you do? Check for endometriosis. Make sure your vitamin levels are high. Make sure you're not smoking, drinking, using drugs, including marijuana. Make sure your weight is appropriate. I would do the Fertility test for sure. Get that testing done and see if the inside of your uterus is normal or not. Most likely, that's a source of the problem. Make sure your vaginal microbiome is normal. So that's where you want probiotics in the vagina after treatment with antibiotics to get rid of whatever is in your uterus that doesn't belong there. You want a lot of Lactobacillus crispatus. You want to make sure that you've got all the right bacteria there and none of the wrong bacteria. So those things are really critical. But everything is important, your stress level. So acupuncture can help. Anything that can reduce your stress can help. The appropriate diet, Mediterranean diet, can be beneficial. Melatonin can increase your success rate. So these are things we've actually built into our protocols now. As this data comes forward, we always implement the stuff that scientifically is sound. So make sure that you're doing all of those things to help you, but not an ERA. My naturopath suggested I should get an AMH test because I had only 4 follicles, only 2 mature, when I took letrozole and Puragon during my last IUI. Is there a specific reason she suggested this? Everybody going through fertility should get their AMH tested, in my opinion. It's a very beneficial test. It's not particularly expensive, and it will yield you a lot of valuable information. It's hard to know if you took Puragon and letrozole, whether 2 eggs is appropriate or not. What's more appropriate is to know how many eggs you had at the start of the cycle before you started your medications, ideally day 2 or 3, which is called an antral follicle count. So if your antral follicle count is low, then that's a problem. If your antral follicle count is normal or high, then your ovaries are still robust, then it's not a problem. So just going strictly based on a protocol won't tell you very much, guys. You need to definitely make sure you know all the details about you and that we know all the details about you so we can guide you appropriately. I've done all my tests, so has my fiance, just wondering what is the next step moving forward. Just make sure you reach out to the clinic, let them know. At the bottom of our instruction sheet for your testing, it says once you've completed all your tests, let the clinic know. We'll set up the call to go over all your results with you. So just call in and let them know. Can you PGS test later on if transfers are not working? You can, but it's an unholy nightmare. Here's your frozen embryo. We thaw it. We pray that it expands. It pushes out the placental tissue through the right part. You laser it, cut off a piece, send it for testing, refreeze the embryo, wait for the result, and then re-thaw the embryo and transfer it. So freeze, thaw, freeze, thaw. Not good for your embryo. So definitely try not to do that. That's one you definitely want to avoid. I've had 2 FETs aged 36, 2 failed PGT normal embryos. One ended in no implantation and the second ended in a blighted ovum. Oh, I'm so sorry. No, I would not recommend Receptiva DX. So none of these things would help. And you got pregnant with a blighted ovum. So that suggests either a sperm or an egg quality issue. It has nothing to do with the lining. If Receptiva was necessary, you would not have gotten pregnant. So that's suggestive that there may be a quality issue rather than genetically normal. You can have a genetically normal embryo and still have it be energy inefficient. If the embryo is energy inefficient, that's a problem for sure. Those are patients that need tons of coenzyme Q10 or, seeing the naturopath or whatever. And even then, it can be difficult to make that work. There was that very promising trial of that sort of procedure called Augment, where they took ovarian tissue, found the quote-unquote stem cell mitochondria, took those mitochondria, injected them into your eggs when they did the ICSI, and then went ahead and tried to get you pregnant. I did 5 cases, 1 got pregnant. Statistically, that would have happened anyways. So I don't think that that's, very valuable or very helpful for you. So don't do Receptiva. It's not going to help you. I am going for my first IUI next week. Congratulations. My ultrasound is on Thursday this week. I have a problem sleeping at night. Can I take sleeping meds? And when should I abstain from sex before IUI? Don't have sex immediately before or even the night before. You want to wait at least 1 day in between. As far as taking sleeping meds, you cannot take sleeping meds when going through IUI. So take melatonin, which actually helps you sleep and improves your fertility. So that's an easy one. Wow, here's an interesting one. Let's put that one up. Do you have any information if being on ephedrine and mestinon medication will interfere with fertility? I trust your advice way more than Dr. Google. Well, thank you to someone I know well and love. Ephedrine is definitely going to mess with your infertility or fertility because ephedrine tightens your blood vessels, which is going to reduce blood flow to target organs. So ephedrine is a problem. Mestinon, I'd have to look into. I don't know, but I will get King, our pharmacist, on it, and she can tell us. She's amazing, all those of you who know her. But ephedrine for sure will be an issue. Ephedrine squeezes blood vessels, increases your heart rate and your blood pressure. So none of those are good things when you're trying to get pregnant. So that's one you definitely want to avoid. Okay. Let's see what else there is. Oh, I think we're done. Okay, folks, last check. Anyone have any questions? Otherwise, I actually get off early once. Do you have anything else there?
No.
No. Okay, awesome. I'll hang on for 1 second. Oh, there you go. There's always someone that pops on. Last minute questions. I have polycystic ovarian syndrome. I've been taking letrozole for a couple of months. I've been ovulating on the letrozole, but not getting pregnant. She told me this is the last round. I'm taking the highest dose already. Okay, well, I'm sorry it hasn't worked. Letrozole alone in women with PCOS has a 27.5% chance of live birth after 6 months of use. So if you've only been on it for a couple of months, it's not shocking that you're not pregnant yet. It's super frustrating that you're not pregnant yet. But statistically speaking, that's normal. That's what we would anticipate. So if you want to up the ante, give it a better shot, you either add in insemination or you add in shots, which will improve your chances. But definitely don't do anything drastic until you've tried for somewhere between 3 to 6 months, because that's kind of a minimum for just letrozole. And if you're young and you have PCOS, you have loads of time. So save yourself some money. And as long as it's not over frustrating or taxing for you emotionally, mentally, go for a few more months for sure before you change your mind. Good evening. When can you have sex after an egg retrieval, please? And thanks for your above and beyond support to create that day's very caring. Oh, my pleasure. You can have sex 2 or 3 days later. By that time, any eggs that are floating around that somehow didn't get caught, which is extremely rare, will have dissolved or missed their opportunity to fertilize. So 3 days later is probably safe. You will be uncomfortable. So to all the guys watching or the women, if you are having sex after a woman has had an egg retrieval, gentle, like super gentle, to the point of being boring. Because if you're going for it, it's going to hurt. And if your ovary is big enough and you do something crazy, you can twist the ovary, which is ovarian torsion. That's then a surgical emergency. And in many cases, incorrectly, physicians were trained to remove the ovary instead of just untwisting it. So if that happens to you for any reason, don't let them take out your ovary. Make sure you tell them you just want to, have the ovary untwisted. It will come back. Is Adalat XL okay while going through fertility treatment? It's totally okay while you're going through fertility treatment. Adalat and labetalol are both blood pressure medications that are actually safe in pregnancy. Every once in a while, we get someone that's on an ACE inhibitor, and those are totally not okay. So make sure you're on either Adalat or labetalol. Those are the only two that are okay. I don't know if anybody else tossed in anymore. Oh, how many hours before the transfer should we take PIO and suppository? PIO, you should take it at the same time every day. Your suppository, you could probably wait till after we do the transfer, just because otherwise I got to wipe it all out of you. So don't worry about that too much. And they asked again, transfers at 9 and they normally take them at 8:30. So your PIO, you can take at 8:30. Just wait until after the transfer, and then, or at the time of the transfer, I can pop it in there for you if we're doing it. Yeah. Ooh, our Spanish patient sent me a emoji with the hard eyes. So I guess I got the question right. My Spanish, bizarrely, I've never taken a word of Spanish in my entire life, but for some really strange reason, I can vaguely understand it. Don't ask, I have no idea how that works. So hopefully I got the question correct. Does melatonin react with Synthroid? Everything reacts with Synthroid. So generally speaking, they tell you to take your Synthroid apart from one another. I'd have to ask a pharmacist that question, but I don't think they specifically interact, but Synthroid reacts with everything. So they always tell you to take it separate from everything else. Back to the Facebook question about PCO. Also, she told me since I go months without having my period, not safe, I could end up having uterine cancer later on. I think they meant uterine cancer later on. Should I look into getting fixed? We are done trying, giving up too much to handle. Okay. So first of all, do not give up. You're trying something very, very simple. With just taking letrozole. So don't give up. There's loads of options for you, and we have loads of people here to help you. So we've got our naturopath, our social worker, our psychologist, a family doctor that does counseling. I've got an online course I offer for free to all my patients because I pay for it so you can have it. So don't quit. Remember, quitting is not going to get you to where you want to go. So please don't quit. Stick with it. I don't want you to spend any money. Like I said, you don't even need to do anything. Just keep trying the letrozole. Sooner or later, it will work. Make sure your weight is appropriate. Make sure that your health is appropriate, your diet's appropriate, exercise, vitamins, all of that stuff. But you don't have to quit. You got loads of options and lots of time if your diagnosis is PCO. In addition, you do need to be careful if you are having irregular periods, because that is a risk factor for uterine cancer, endometrial cancer. It is not safe for women to not have regular periods. So make sure you're getting checked. Getting fixed, which is tying your tubes, is not going to solve that problem. You either need to be on the birth control pill, have an IUD placed, or actually remove your uterus, which we don't want you to do. Get pregnant first. Did you say the Fertility test? Oh, it's called the Hidden C for chlamydia, 12-in-1, which actually adds in a bunch of other things, and then add HHV6, human herpes virus 6, to that test. Our friend on Facebook is saying we did IUI, didn't work. Well, sometimes you have to try more than once. Sometimes you got to address all those other factors, like I said, the weight, the vitamins, all of those things. So those are important too. And sometimes IUI doesn't work. So that's what IVF is there for. So don't give up. There's lots of options, and we're more than happy to try and help you whatever way we can. But definitely don't give up and have a hysterectomy. I mean, with PCO, you have loads of options. Okay. Thank you for always going above and beyond for your patients. Oh, you're welcome. I can't speak more highly of you or your clinic. Super comfortable with you all and your employees, which is amazing. So thank you. And thank you. I love all you guys. I love doing this show. It's fun. And thank you to Tarek Ibrahim from Ibrahim Strategies Group, who is awesome, and we couldn't do this show without him. And to my family who puts up with me being here late every Monday night or Tuesday when it needs to be Tuesday. So until next week, guys, we're signing off. Have a great night. I hope you enjoyed the show. remember to comment, remember to like, remember to share. We will definitely go through more of these, and we'll keep them coming. And if you think of any ways we can improve the show, let us know. I'd love to maybe interview some of you guys sometime and see what you think of things. Have a great night, guys, and we will talk again shortly. Signing off, Fertility Fact or Fiction. Take care.